Dear Chairman, dear colleague, ladies and gentlemen, first of all, really I would like to thank very much Dr. Cengiz Koksal and all the organizing committee for inviting me to participate to this very interesting symposium. It's really a privilege, an honor, a pleasure to be here with all of you. And the title of my presentation, you can read on the screen, is a patient-specific surgical solution for functional mitral regurgitation. This is a rather interesting topic, mainly because functional mitral regurgitation is an important topic and a controversial topic after many, many years, almost 20 years from the introduction of the most widely adopted surgical technique to repair it, which is undersized annuloplasty. So I will try in those 25 minutes probably to try to give you my point of view about this topic, which is the result of some data coming from the literature, but also from our own experience. We do have, you have to know, in our hospital, since more than 12 years, a dedicated outpatient clinic who has been following those patients since 2000 almost, the year 2000. And therefore we have, of course, developed our own thinking about this, which I will try to share with you. I will not go too much in details in terms of physiopathology of this disease. Probably you know better than me. I will just briefly recall that functional mitral regurgitation, of course, is not a problem of the mitral valve, it's a problem of the ventricle. And this is one of the most typical situations. You have a patient with ischemic mitral regurgitation, a patient with an inferior myocardial infarction, a local remodeling of the left ventricle, a displacement of the posterior papillary muscle, and this is responsible for tethering involving mainly the posterior leaflet. If you get tethering of the posterior leaflet mainly, you get a regurgitant eccentric jet directed towards the posterior wall of the left atrium. Usually you get a posteromedial commissural jet in a patient who has got also dilatation of the mitral annulus. And this is the other most common situation we can face. Those are patients with dilated cardiomyopathy, idiopathic dilated cardiomyopathy, or with very advanced remodeling, left ventricular remodeling, due to advanced ischemic cardiomyopathy. In this case, you see the difference. You see the ventricle is globally remodeled. You have a displacement of both papillary muscles. You have tethering of both leaflets. And then you get a central regurgitant jet, functional MR with a central regurgitant jet. And so if you look at the echo, you already know, you can get already and appreciate the difference, understand that you are facing two different situations in terms of physiopathology and possibly treatment. Now, this is the operation which has been introduced about 20 years ago, in 1995, by Steve Bolling, undersized annuloplasty, at that time with a flexible ring, to treat functional mitral regurgitation. And what I would like to remind you is that the message given by this important colleague was very simple at that time. Find MR, fix MR. That was the message. Find MR, then use a ring, the smallest possible, at least 2 sizes smaller than the annulus of the mitral valve. In this way, you will force the coaptation of the leaflets, which have been tethered by the remodeling of the left ventricle, and you will abolish successfully mitral regurgitation. Find MR, fix it simply and quickly, because those are bad ventricles with very low ejection fraction. After 20 years, we have learned that it doesn't work as simple. It is not as simple as that. Here you see the incidence of recurrence of mitral regurgitation, and here you see the follow-up. 10 days, 30 days, 3 months, up to 5 years. And those you see the names of the first authors of the papers are most of the papers which have been published on this topic over the years. And you see that all of them do report a variable but significant rate of recurrent mitral regurgitation. You can have residual mitral regurgitation immediately after surgery. Here it's 10 days after surgery. Or you can have recurrent mitral regurgitation a few years, usually within the first 2 years after surgery. So it is not as simple as it looked to be. It's not enough just put a ring in every patient. You have to look at the patient and see if the ring is enough or not. Does this matter? Is it important if we do have or we don't have recurrent or residual mitral regurgitation. It is very important because mortality in the follow-up is strictly related to the presence of residual recurrent mitral regurgitation. And you see here very well this data. Those are patients with recurrent mitral regurgitation and without, with and without residual recurrence, or recurrent MR. And you see that survival is significantly different. You see even better in this study where recurrent MR was associated with a event-free survival, which was much lower compared to patients without residual recurrent mitral insufficiency. Now, the problem is that no benefit on patient outcome can reasonably be expected if the target lesion, if the problem is not fixed. If you have a population and 1/3 of your patients are left as they were before surgery, which means with the same almost degree of regurgitation, 1/3 of the patients, there is no benefit. You should wait looking at the overall population. And that to me is the main reason why we have been unable so far in the studies published so far to show a survival benefit in patients treated with surgery compared to those undergoing medical therapy. This is probably the most important paper published by the Steve Bolling group, reporting similar survival in patients with medical therapy and undersized annuloplasty operated between the 1995 and 2002. Those are propensity score matched patients, but the most important point, if you go through the paper, 30% of those patients had significant 3+ recurrent mitral regurgitation, and the impact of this recurrence was not assessed at all. And so it is not really surprising for me to see that there was no benefit in terms of survival. So we need to avoid the residual recurrent mitral regurgitation. And how can we do that? This is a slide I really copied from Dr. Bolling. I liked it at the American Heart Association. I think the principle is very good. In mitral valve surgery for functional mitral regurgitation, we do not have 2 options. We have 3 options. We have a good, which means durable repair. We can perform a replacement, or we can have a bad repair, which means a repair which seems to be effective initially, but which is going to be not durable. And so the first thing we need to do if we want to have a surgical specific solution is to understand how to avoid bad repair. Let's start with that. Let's start avoiding doing wrong things in the wrong patients, and then we will see the rest. How can we avoid bad repair? The first point is that we need to be very selective. If we are going to use this simple solution, because technically it is very simple, just to put a ring on a mitral valve, if we are going to use this isolated undersized annuloplasty, we have to be very selective in choosing the candidates. Certainly we need to use complete rigid rings in this setting. It has been shown in prospective randomized study that if you use complete rigid rings, the rate of recurrence will be 5 times lower compared to flexible bands. But we have to reserve this procedure to patients in the early stage of the disease, when there is no advanced remodeling of the left ventricle, and when we have no predictors of repair failure. So we need to understand which are those predictors of failure of the repair. And I brought with me a few examples of our experience and coming from the literature. As you can see here, 03, this is the year, 2003. This is a patient we've been operating in 2003. And this patient had those which to me and to many other people are really important predictor of bad repair by using an isolated undersized annuloplasty. If you want to work on the annulus and you want to force the coaptation of the leaflet, you need a huge annulus because you have to restrict it and force the coaptation of the leaflet. If the annulus is not dilated, you cannot force the coaptation because you will not be able to shrink the annulus itself. So this patient had a modest, a very mild annular dilatation. You can see here the mitral valve. The septolateral dimension was 27 millimeters, and you will see soon. You see, the mitral valve looks quite small. Look at here. It seems to be already the ring to be present, but there is no ring. This is really the mitral valve, which is very small in terms of annular dilatation. And the regurgitation is mainly due to tethering of the leaflets. We are measuring this tethering. The coaptation depth was 1.7, so much higher than 1.1. In this patient, we put in the smallest ring at that time, a Sagan complete ring 26, and it seems to be working at the beginning. After less than 1 year, you see here, this is the follow-up, again in the year 2003, after less than 1 year. And you see that the leaflets are almost not touching, and you get severe recurrent mitral regurgitation. So if you today have a patient like this, you should not perform an isolated undersized annuloplasty because this is going to fail. So we can start to recognize those patients. This is an important predictor of failure. If you have a patient like this one, you see this is the posterior leaflet of the mitral valve. You see that in this patient, the posterior leaflet is very much tethered. If you measure the angle between the annular plane and the posterior leaflet, this angle, it will be more than 45 degrees. If you have a patient like this, isolated undersized annuloplasty will not work. Because when you use an undersized annuloplasty, you push the posterior portion of the mitral annulus forward, and you will just make worse this already advanced degree of tethering, and the repair is not going to be durable. What about the anterior leaflet? We can do the same type of consideration. This is the anterior leaflet. This is the seagull sign due to the fact that the secondary cord, they are responsible for tethering of the body of the anterior leaflet. You see the shape of the anterior leaflet. But the portion of the anterior leaflet which is going to co-opt is not the body. It's not this one. It is the tip of the anterior leaflet. So if we want to measure the severity of tethering, we have to look at the tip of the anterior leaflet, and we need to measure this which is called distal anterior leaflet angle, which is the angle between the tip of the anterior leaflet and the annular plane. If this angle is less than 25 degrees, or if this angle is more than 25 degrees, completely changes the outcome. And this has been shown by Lee in Circulation 2009. You see those patients are very similar. This one has got a distal anterior leaflet angle which is rather small, as you can see. This one has got a much larger anterior leaflet angle, and this one has got a very important tethering. All those patients received an undersized annuloplasty, but 6 months after surgery, you see this patient had no MR because the anterior leaflet was able to compensate for the increased tethering of the posterior leaflet. This one had mild MR, and this patient had severe recurrent mitral regurgitation. You should have expected this before putting the ring because of this pathophysiology you can assess before surgery. And then we have other important predictors of bad repair, which mainly are related to the degree of remodeling of the left ventricle. If the left ventricle is very remodeled, very dilated, and diastolic diameter more than 65, I'm not sure if the cutoff, which has been reported by Dion and co-workers, is exactly this one, but certainly the larger the ventricle, the worse the outcome. If the systolic sphericity index is more than 0.7, if the papillary muscle are very much apart one from the other one, more than 2 centimeters, if the end systolic volume is higher than 100 milliliters per square meters, it is very likely that this remodeling will go on and you will get recurrent mitral regurgitation. This is our experience as well. Patients with a longer duration of congestive heart failure, which means with more remodeled left ventricle, they had higher rate of recurrence of MR, as you can see here, and lower rate of reverse remodeling. So the early treatment and no predictors of repair failure are the key to obtain left ventricular reverse remodeling and a durable repair. These are the points we should focus on. Now, since we have to be practical, this is the patient who is coming to you in your outpatient clinic, as it happened to us a little bit more than about 2 years ago. This is a 40-year-old gentleman. He has got increasing shortness of breath, 3 pulmonary edema in the last 6 months. He has got no coronary artery disease. He has been classified as having idiopathic dialytic cardiomyopathy. And transesophageal echocardiography shows severe functional mitral regurgitation and severe left ventricular dysfunction. He was sent to our center. I show you the echo. Ejection fraction was 30%. Severe functional mitral regurgitation and diastolic diameter was 70 millimeters. He had also 2+ tricuspid regurgitation with a dilated tricuspid annulus. and some dysynchrony, which was due to right bundle branch block, not left, but right bundle branch block. You see here how severe it was, is functional mitral regurgitation. Now, the question we need to ask ourselves is, I'm thinking about performing a repair in this patient. Is a good repair possible in this case? So we try to understand that. We look at the annulus. In this patient, the annulus was 47 millimeter septolateral and 43 intercommissural. So the annulus is certainly dilated, which is a good news in terms of durability of the repair. Then we look at tethering, and we can measure tethering. And this is about 1 centimeter, no more. So it is not extreme in terms of tethering. We look at the jet. The jet is rather small in the central portion of the valve between A2 and P2. And we look at the degree of symmetry of the tethering. You see both leaflets are involved in tethering, and which is rather symmetric, involving both the anterior and the posterior. How much those leaflets are tethered? We look at the posterior one. This angle is 30 degrees, so less than the 45. And this other angle, the anterior leaflet, is 17 degrees, so it is less than 25. So I think we can do a good repair in this patient. Should we do something strange, very difficult, cut secondary chordae, plicate the left ventricle, enlarge the posterior leaflet? I don't think so. I think that we can put a good undersized complete ring and it will work. And if we do surgery, we can treat also tricuspid regurgitation because this patient has got already 2 plus TR, and he has got also permanent atrial fibrillation, which is very important because it's 1 year he has been in permanent atrial fibrillation. And we have learned, according to a series of cases we have been treating, that reverse remodeling, that permanent atrial fibrillation can have a major contribution on the severity of left ventricular remodeling and dysfunction. So if we are able to abolish atrial fibrillation, if we are able to restore sinus rhythm, this can significantly improve LV function. More than the isolated repair of the mitral valve. We are doing something more. We are repairing the valve and we are restoring sinus rhythm. That is a reason more to operate the patient, not a reason less to prevent him from getting surgery. And we have shown this in a paper we published last year, where in patients with idiopathic dilated cardiomyopathy, restoring sinus rhythm by abolishing atrial fibrillation was the most important independent predictor of reverse remodeling of the left ventricle. So what we did was to put a ring, complete, 28. We looked at the tricuspid valve. We put a ring there as well. And then we did the surgical ablation with the radiofrequency ablation and cryoablation of the permanent atrial fibrillation. And this is immediately after surgery. You see the small ring here. There is no residual mitral regurgitation. This is the mitral valve. Please look carefully at it. I think this is one of the most important messages we should take home. Those leaflets are coapting for a long distance. You see the anterior leaflet, how it is going over the surface of the posterior leaflet. We can measure this length of coaptation, and it is about 1 centimeter. This is a very important predictor of durability of the repair. If you look at this and you ask yourself, is this repair going to be durable? It is very likely it is going to be, because 1 centimeter is the length of coaptation of the 2 leaflets. Tricuspid regurgitation is abolished with the ring, and the patient is in sinus rhythm. You can see that the contraction is rhythmic. At hospital discharge, LV function is not that bad, and after about 18 months, ejection fraction is 40-45%. It was 30% with severe MR, and the patient had a major improvement in terms of symptoms. Of course, we have, as you have heard before, we have the mitral clip option, which is available. And one question we asked ourselves during the meeting we do in the morning is, should we put a mitral clip in this patient? The mitral clip will be rather safe in terms of danger for the patient. And probably we would have done that if this was a 75-year-old gentleman with a lot of comorbidities, but that was not the case. This is a young patient with low comorbidity. And if we were going to put a mitral clip, we would have not addressed atrial fibrillation, tricuspid regurgitation, and the rate of residual recurrent MR expected would have been much higher. This is our own experience in San Raffaele, published in the European Journal, with MitraClip and with surgery. And you see that there is an important difference in terms of recurrence of mitral regurgitation, which is significantly higher with the MitraClip compared to surgery. So the best thing we could do for this patient was surgery, and that's what we did. Now, let's suppose that this patient had the situation I showed you, but this patient, let's say that he was in more advanced remodeling of his left ventricle. In that case, we have two options. Isolated underside annuloplasty will not be enough. Either we do additional procedure or we just replace the valve. And that is the question. What we have been doing in our institution, particularly in the past, it has been to use a tailored approach. Patients as the one I showed you with a small coaptation depth has been treated with the ring alone, and patients with a more important tethering has been treated with a combination of ring plus edge-to-edge to force the coaptation of the leaflets. We have published the results in Circulation, and you see that there was a significant difference. Patients with edge-to-edge plus ring had a much higher freedom from recurrence of mitral regurgitation. Other groups have done similar things. This is a group from Germany, it's Schaffer's group. They're using the ring plus string technique. You have the ventricle which is very dilated, then you put a stitch on the head of the papillary muscle, you come out with the stitch through the mid-aortic curtain, and you tie the stitch off pump. In this way, you decrease tethering. This is preoperatively. This is after the string, and you see that the leaflets are coming up just because you pull up the papillary muscle. And they were able to show as well a difference in terms of freedom from mortality and freedom from recurrent MR, which again was significantly better with the ring plus string procedure rather than the ring alone. And you can use many other techniques. You can use cutting of secondary chordae. You can pull up the posterior papillary muscle, so-called Crohn operation. You can approximate the papillary muscle with a sling, as showed here. You can enlarge the anterior leaflet, enlarge the posterior leaflet. You can do many things. The problem I ask myself, and I ask you, is it worthy? I mean, we have two possibilities. One possibility is to perform a quick operation in very sick patient, very standardized, just putting a ring, in patients who need to be very well selected and have a successful result. The other possibility is, since remodeling is more advanced, we start doing more complex things, but this is not free, because this means longer cross-clamp time, long-term results are unknown, so we have to think if that is worthy or we should just replace the mitral valve, maybe with a biological prosthesis and preserving the subvalvular apparatus. So the question is it the same repairing or replacing a mitral valve in the setting of dilated cardiomyopathy, functional mitral regurgitation? In our experience, the answer is no. We had better results with mitral valve repair compared to mitral valve replacement, but we all know that there are many other studies, those are large series from Italy and from Mayo Clinic, saying, look, the results are the same. If you repair the valve or if you replace the valve in those patients, survival is absolutely the same. What is the problem with those results? Is again what I call the problem of the elephant in the room. It's such a big problem that it seems to be an elephant in a small room. And the problem is again the same, recurrence of mitral regurgitation. Those series comparing mitral valve replacement versus mitral valve repair, they do include in the repair group 25-30% of the patient with recurrent mitral regurgitation, which means untreated patients, practically. So this comparison does not work. Even if you adjusted everything, renal failure and renal and pulmonary insufficiency with propensity matching or whatever, the most important problem is that you get in 1/3 of the patient recurrent MR. So those studies, what we have been comparing with those studies are good repair plus bad repair in the same population versus mitral valve replacement. If we want really to understand, and we hope we will have the results of the randomized trial which is ongoing in the United States, If we want to really understand if repair or replacement is better in this setting, we need again to compare, to select the patient, avoid bad repair, and compare good repair versus good mitral valve replacement. And if a simple repair, this is what I personally think, if a simple repair, a quick repair, undersized complete ring is unlikely to be durable, and we can foresee that because we can look at the patient, measure what I showed you, and decide if it's going to be durable or not. If a simple repair is unlikely to be durable, then I think that a good replacement is probably better than a bad repair or a complex repair requiring a long cross-clamp time. So to come back to the title of my presentation, if you ask me what we should do to have a patient-specific surgical solution in functional mitral regurgitation, I would say again that we need to start with the first step. And the first step is avoid bad repair in unselected patients. So the message Steve Bolling gave to us 20 years ago is nice, but it's not actual anymore. We should not think in terms of find MR, fix MR, but we should think in terms of find MR, carefully assess the patient, look for predictors of failure repair, and once you have decided, choose to tailor the surgical solution to the individual patients, maybe as I tried to show you in those slides. Thank you very much for your attention.
İki soruluk vaktimiz var. Soru sormak isteyen? Any questions? What's the reimbursement issue of mitral in Italy, Dr. De Bonis? The reimbursement issue of mitral clip in Italy. In Europe, in Turkey, we have reimbursement in Turkey, surprisingly, but what's the issue in Italy?
Yes, sir, I apologize. I was listening to the translation, but you were speaking English, so he was translating to me in Turkish, which was, I was not understanding for that. Sorry, did you ask for reimbursement policy in Italy? That's
for mitral clip.
Yeah, for mitral clip. Mitral clip is rather expensive. Of course, it depends on the number of procedures you are performing. You can get better prices if you do a lot of procedure, probably. In Italy, the situation, you are asking me in Italy. Yes. In Italy, the situation is very regionally regulated, which means that according to the health policy of every single region, and in Italy we have 20 regions, you can have the procedure reimbursed or not. For instance, in our region, where Milano is located, which is Lombardia, we get reimbursed, but we get reimbursed just for people living in our region. So it's really something which is ongoing, and I think that the more data we get in terms of effectiveness of this procedure in high-risk patients, the more it will be available for politicians to say, okay, this is a procedure you need to have in your armamentarium. At the moment, it's still, not completely regulated, regionally regulated.
Balkan Hoca.
Konuşmacılara ben de çok teşekkür ediyorum. Günümüzü aydınlatıyorlar. Şimdi özellikle ben bu soruyu Alfieri'ye sormak istiyordum ama fakat aynı şey. Şimdi mitra kliplerden konuştuk. Biraz önce anlattınız. Bu mitra kliplerde bizim anulus'a ring koyma şansımız yok. Şimdi bu Alfieri tekniğinde ring koymadan yaptığınız uygulamalar oldu mu? Sorunun birisi bu. İkincisi de son zamanlarda özellikle hipertrofik obstrüktif kardiyomiyopatide SEM etkisini önlemek ve Venturi'yi yok etmek için bu Alfieri tekniği kullanılmaya başladı. Böyle deneyiminiz var mı? Yine o olgularda mutlaka ring kullanmak gerekir mi? Teşekkür ediyorum.
Okay, thank you very much. Those are very, very interesting questions, I have to say. The first one is the use of the mitral clip without ring. So from a surgical point of view, we have been using the edge-to-edge technique, particularly at the beginning of our experience, also without ring in a certain number of patients. In 2 weeks' time, in Dallas, at the American Heart Association, we are going to present the 10 years results of those patients operated with edge-to-edge technique without ring. I can anticipate to you that the results of those procedures are not comparable at all with those performed with the ring. They are much worse, of course. Many more reoperation, many more recurrence of mitral regurgitation. This on one side. But you have also to consider that those patients who had a ringless procedure, they had the most complex situation. For instance, the ring was not used because of severe calcified posterior annulus. So there are also the worst patients. The final message in terms of mitral clip use implication is that in this series we are going to present, if you were able to use your edge-to-edge without ring very effectively at the beginning, which means that immediately you had no regurgitation at all, you can expect a freedom from severe mitral regurgitation at 5 years, about 80%, 5 years, which is not too bad if you are talking about inoperable patients in whom you are going to use the clip. But the other point is that you need to know that in just 3 months ago, we have been performing in our institution the first completely percutaneous annuloplasty. There is the way, and there are several cases now which are going to be presented, in which we have used percutaneously a complete posterior band from trigone to trigone, transeptally, going through the femoral vein. So we are already in the step where we can use the mitral clip together with the possibility of performing a percutaneous annuloplasty. So this is the second question. The third one is hypertrophic cardiomyopathy and risk of SAM. I think this is a very important point because we really have been treated quite a few patients now. I don't know exactly the number, but the edge-to-edge, central edge-to-edge, is probably our first choice in patients who have hypertrophic cardiomyopathy and preoperative SAM. You can avoid putting the ring because usually those annulus are rather small, and you don't want really to treat severe MR because of an organic reason. You just need to treat the functional component. And it has been in our hands very effective in preventing SAM. So absolutely a very good indication, I think.